Okay, everybody, we are just about ready to start. Good morning. For those of you that have joined, we'll just give it another minute or so. All right, so it's 10 o'clock and I think we should get started, and I'll tell you why that's important to be timely in just a second here. But welcome to the Behavioral Health Urgent Care and Crisis Stabilization Workgroup meeting. This is the fifth, I believe, of our scheduled 6 meetings. So we are just about nearing the end. We do have a few things, some work to accomplish still, but we'll get into that in a moment. If you wouldn't mind, please, just a reminder, the meetings are being recorded. Also, if you could enter in your name and title and organization into the chat box by way of introduction, that would be helpful. Right off the bat, I'll let you know about a slight change in our schedule for today, and then I'll turn it over to Tim. But we are going to be on a compressed schedule for today's meeting. Unexpectedly, we need to limit this to 10:30 to a 30-minute meeting. And I guess I'll let Tim explain why. So we'll have to make some determinations on the fly here of what we want to prioritize, but I'll turn it over to Tim to explain a little bit more.
Yes, good morning, everybody. I appreciate everybody joining again, and I suspect we're also going to be short. I know I got a number of messages from folks who routinely participate in this. There is a hearing at being facilitated by the Children's Committee at the LOB that begins at 11. And a number of the participants in this work group have been invited to attend that, including both myself and Jeff. So the co-chairs of this group, the co-facilitators of this group, have been asked to join that meeting too. So we'll be, our work in this group is close to being finished, but it is not completed. So we do need to push forward and at least spend 30 minutes. So that was the main reason for cutting today's meeting short. So we'll give you back about 30 minutes at 10:30. So appreciate again everybody's joining.
So what I'll do, thank you, Tim. What I'll do is I'll open up the PowerPoint and we'll just dive right into it. We want to hear people's thoughts on the recommendations on behavioral health urgent care, as well as the beginning of model elements on crisis stabilization, if we can get to that. So let me pull the other one up just a moment here. Okay. So just a few slides that we wanted to share with you all on our behavioral health urgent care model review and some early considerations on crisis stab. As a reminder on background, this has all been a lot of this, at least. So the genesis of this work group is around the volume of visits to hospital emergency departments, the elevated clinical acuity and intensity of needs for young people. I think as we've discussed extensively here, that the behavioral health needs of youth in the emergency department can result in significant wait times before receiving services. There's traditionally been a lot of variability across emergency departments in their ability to address the needs of young people with behavioral health conditions that present. And then also the reality that most youth that present to an ED are not subsequently admitted inpatient. So it raises the question about how we facilitate timely connections to community-based care. So that's sort of the context of the report. And you may recall reading that in more detail in the actual Word document that was distributed both at the last month's meeting and also for this month's meeting. Pretty much the same. So the goals that we set out to take on. Is there a question, Carl?
Yes, there. Oh, Jeff, thank you. Yes, there is. And back to the background and rationale slide. And good morning, everyone. And I think my hand unraises itself, but if not, I'll get it down. One of the things that I thought we should discuss as a group with respect to background and rationale, and of course, this is not unique to to emergency departments. Is the increasing challenges to have staff on duty to provide this care. while patient volume is rising with respect to, children with behavioral health needs, I wanted to throw out there for discussion whether this particular slide merited our including a bullet acknowledging the staffing challenges that have, plagued all of us across the continuum and even outside healthcare, because it's very real. We might have the beds, we might have the facility, but in many instances, we simply don't have staff available. So I'll just throw that out there, and thanks for letting me make that comment.
Tim, anything you want to add? I think we try to, in this work group, put the findings and recommendations into a context on urgent care. And I do think that the workforce challenges that Carl is pointing out are really important context for this, for the recommendations of urgent care. Tim, anything to add there?
Yeah, I guess there's no reason why we couldn't add the current context to this. I just wanted, my also thought for this was, this has been a long term, that this work group actually preceded the pandemic. So I mean, we were on the way for the work group and the development of this. And what my point is that the Behavioral Health Urgent Care Center and concept and crisis stabilization was part of our plan from, 6 years old. So there is the long-standing context that the challenges in the ED has been rising, and certainly the pandemic has exacerbated that. So that's a point as well. But I do also agree that we could, in the recommendations, in the setting the context for putting forth, is that the current hiring situation across the system is going to be challenging in putting forth a model. I think the bottom line of the recommendation is we still want to put forward a recommendation to stand up a behavioral health urgent care center, understanding that we are hopeful that the staffing challenges could be and may be overcome, but that during the implementation phase, it will be a challenge to continue to do that. And hiring will require more efforts than have historically. So it's well worth including that.
Okay. So we'll definitely make a note of that, Carl, and make sure that we kind of appropriately contextualize around workforce challenges. I see you're off mute. Did you have something else you wanted to say? Oh, anything, Carl, anything else? You're good?
Just to thank you. Appreciate it.
All right, great. Okay. So, so in terms of the behavioral health urgent care goals, they look fairly similar to the last version of the report. I believe there was one thing that was added. Elise, can you help me? I think we may have added one goal over the last couple of weeks based on discussions at our previous work group meetings.
Yes, we did the psychiatric assessment and ruling out medical concerns.
Okay, so number 3 was added within the last few weeks based on discussions of the last couple of meetings. So one of the goals of urgent care would be to provide that level of assessment and ensure that young people presenting to urgent care don't need to be transported to the emergency, or well, some might. Essentially providing a level of assessment that allows urgent care to hold on to those kids who are there for behavioral health concerns, but also can make a transfer to the emergency department for those young people who are experiencing medical condition that requires emergency department level of care. So we added that as a goal to the urgent care as well. Any questions about the goals?
I'll just make a comment. It probably doesn't need to be put down as a goal, but kind of in relation to the medical concerns aspect of things, I think a consideration could be the ability to provide telehealth, or the EDs to provide some level of emergency telehealth to the urgent cares if there's question, but not, ultimate concern for a medical condition, but they just want some guidance to make sure. So something to kind of consider since we're in the telehealth age.
I think that's a fabulous suggestion. I love it. We'll definitely add that. Yeah, and again, to your point, not whether it's a goal or not a goal, it's something worth adding somewhere in the document. So yeah, it's really good. Okay. All right, hearing no other questions, let's continue on here, and we can always go back to things. Carl, this starts to kind of get into what you were discussing earlier, and number 5 talks about the workforce, so we can make sure that we just kind of flesh that out appropriately so that it's clear that, you know, this will not come without challenges. But there are a number of, we heard very loud and clear from this group that let's not just talk about standing up an urgent care center as a new level of care without also attending to the need for lots of other investments and enhancements that are going to be needed in the system. So that certainly includes inpatient bed capacity as a really important part of throughput in the emergency department, as well as PRTF bed capacity. We've also spent a fair amount of time in this group talking about the role of mobile crisis that they currently play, as well as how that role could be enhanced, particularly for those young people who are not not going to be referred for inpatient hospitalization. We also heard in this group and in other groups for that matter, the importance of the intermediate levels of care, and that includes both center-based care like partial hospitalization, IOP, EDT, but also our intensive home-based service array, and that's services like MST, ICAPS, MDFT, et cetera. And then number 5 is the point we were just discussing around behavioral health workforce challenges. And then finally, available technology for real-time tracking. And Jason, maybe this is a place also in terms of systems context where we can talk about the increased capacity and role of telemedicine in our system and how that can continue to be leveraged for urgent care as well. Great. Carl.
All right, sorry, everybody, I'm a hand-raising guy. And thank you. Item number 4, enhanced intermediate levels of care. I'm just thinking about our target audience for this information, and so this may not be necessary, but Jeff, as you recited sort of examples of what we mean by intermediate levels of care and specified that it includes in-home options, I was just wondering if we could make that item a little more clear by listing those examples, like PHP, IOP, in-home, however it works.
Yeah. Just
to make sure the world knows what we mean when I know we all know what we mean, but will the rest of the world know?
Yeah.
Just a thought.
Definitely. Great suggestion.
Yeah, it just, this where the PowerPoint has got pulled out of the narrative. So the narrative will be more descriptive, but we'll be sure that, everybody sees that.
And Sherry?
Morning, just a quick follow-up to his comment. Where does respite care fall?
Yeah, good question. Actually, Tim, why don't you tackle that one? Because I know that's another definitional, it may be a planned level of care, but it's not one we've talked much about in this.
Yeah, so actually, I was just writing a text to Elise on this very issue. So the best practice document that SAMHSA has put forward does include, as part of the crisis array, crisis respite as different and as separate as crisis stabilization. You just have to be clear about what it is you want to accomplish and how it is in fact different and unique. And historically, excuse me, some of the better practices was crisis stabilization is for that higher level of acuity, but maybe not, maybe a step down from the inpatient acuity level. And crisis respite will often be shown up to 15 days, 30 days, and even 45 days out there nationally, I have seen. And we will include it. We haven't spent time talking about it. One of the main reasons for not talking about it probably, but it's come up everywhere, and we definitely want to actually tackle it, is that's probably one, DCL's former SFITs that we're still kind of maintaining right now fit that model a little bit better. But we need to make a decision in Connecticut about what the length of stay might be. And then also in the 988 legislation and federal recommendations for funding reimbursement rates, allowing the 988 tax structure, I did not see crisis respite to be included in that, where all other parts of the crisis system were. potentially refundable by the any of the state level taxes that are levied if Connecticut determines that they want to go that rate way. So Connecticut hasn't made a determination about that, but so that's the only comment I have about it. But I do think it's we need to be inclusive of it in the crisis array.
Great. Okay, let's move on. Just carefully watching the clock here because an hour goes by quickly. 30 minutes is going to go by very, very quickly. So as we dive into a little bit more of the detail of this, kind of gets into what Tim was talking about here, is making sure that there's an understanding among our audience about how urgent care fits within that crisis continuum of services, which includes currently the 211 system, but ultimately the 988 system that will be running by, I believe, July of next year. Mobile crisis, behavioral health urgent care, and crisis stabilization. And then you have emergency departments, inpatient, PRTFs, and then as Tim and Sherry were just talking about, crisis respite beds. But again, just more context for our audience so that they understand that urgent care doesn't exist in a vacuum, that it's the intention is for it to be part of a robust continuum of crisis-oriented services. The group also recommended that we have a clear description of the target population for behavioral health urgent care. So first of all, we felt strongly that it should be accessible to all youth who require that level of care, regardless of system involvement, payer, acuity level, diagnosis, et cetera. We think it's important as a group that urgent care is accept youth across all diagnostic categories. So that will have some implications in terms of training and clinical competency for urgent care staff. And then we also at an fairly early on as a group thought that if we do stand up urgent care, and as it's designed to be a very specialized service line for children with behavioral health needs, there was initially some question as to whether youth who are at imminent risk of harm should be in urgent care or sent to an ED. And recall some conversation a couple of meetings ago that we felt like urgent cares would be theoretically in a much better position than emergency departments to address the needs of youth, even if they were at imminent risk of harm to self. And again, keeping in mind that urgent cares will have the capacity and be required by the recommendations to be able to transport to the emergency department in the event of a significant medical need. And then and that's really kind of what I just said is really the last bullet as well. Urgent care, as we're talking about the design of this level of care, should have the ability to directly refer to an inpatient level of care. And I would just kind of harken back briefly to number 6 here, where we talked about making better use of technology for real-time bed tracking. So that so if that bed tracking is in place and urgent care has access to that bed tracking system, there will be a better capacity for urgent care to be able to locate and then arrange an admission to inpatient. Any questions on this slide? Go ahead, Carl.
This is Carl. I'm sorry. You know, the bullet at the bottom has me concerned. I'm not a clinician. I'm not a physician. But I just want to make sure those who are particularly emergency medicine physicians and others understand how that will work. Not me, them. And if the docs and nurses understand how that'll work, I'm obviously fine with them because I follow medical judgment. But are we confident that can happen?
I'm not sure what you're saying, that we shouldn't be suggesting
direct
that.
referral to an inpatient level of care from a behavioral health urgent care center.
Oh yeah, yeah.
Yeah, is that well established? And apologies if.
Yes.
I think they're referring to an inpatient level of psychiatric care.
Yeah. So Carl, I think that can happen. I have questions about whether, given our current inpatient capacity through the state, if it can actually happen within 24 hours, because beds are not immediately available, but there's nothing theoretically that could prevent that. We used to admit kids directly to our inpatient units all the time from the community, and it's good to try and bypass an ED.
Yep.
But it depends on, bed availability, and doubtful it can happen given the current situation with bed availability.
Thank you, Frank.
Yeah, it's also a different model. Normally in normal urgent cares, we don't admit into inpatient from an urgent care, but it makes complete sense in this case to admit from the urgent care model and not have to go to another place first.
I mean,
And
in
I-
essence,
Lane, I saw your hand was up. Go ahead.
yeah, I mean, Frank pretty much said what I was going to say. I think the only thing I'll add is it's not convention in Connecticut for outside places to be able to admit to the inpatient unit. So there's going to be like a culture shift that will have to happen, that will need to be reinforced by the emergency departments. But it absolutely happens in other states. Really, the use of urgent care might make things a little bit more murky, honestly. And what we're really talking about here is a psychiatric emergency department, right? Because of the level of acuity of patients that will be going in. But I think that they absolutely should have the ability to do direct admissions into the inpatient psychiatric units, and that's going to be something that's going to need to be reinforced.
Good point.
And probably legislated. And I didn't mean to interrupt Carl's invitation to the hospital folks to weigh in on that, but I just also wanted to make a comment. There are a number of states and jurisdictions that have also allowed mobile crisis to direct admit. So again, the legislation and the supporting physicians in those situations have to be worked out and connected. So my point is that there is flexibility around, and good practice guidelines around this around. So thank you.
And Steve, I see your comment. We'll do that. We'll clarify and make sure it's clear. We're referring to inpatient psychiatric care. Tammy?
Thanks, Jeff. I agree that we want to create something that is like as versatile and valuable as possible. I do think we don't have to resolve this today, but I think it will be a question that has to be answered. This definition is really everyone. So it would be like pretty much, unless there was an immediate medical issue, you would be sending to this alternative to the emergency department. And I think we will need to, at some point from here to implementation, tackle that question of who really goes to the ED versus who really goes to the urgent care center. Because I think here there would actually be no triage, largely, other than this kind of medical rule out. And I think that there's probably a behavioral health, there's probably something that we could identify that would say, actually, this is an emergency. They need to go to the emergency room versus they need to come to the urgent care center. So this is kind of, it almost looks like no eject, reject, like a DCF. And I just think there's probably someone who's not appropriate, and we're going to have to probably tackle that more specifically, but probably not today.
All right. Thank you, Tammy. I see. Jason, is that an old hand up or is that a new one?
No, quick comment to what Lane actually said before, and something that perhaps should be considered. She referenced we're talking more of an emergency psychiatric than urgent care. The important point that came to mind is reimbursement in sustainment of something like this. It may behoove the group to consider it as an emergency department for reimbursement purposes, but additionally, not precursory to changing, regulations and things, but a majority of patients do have Medicaid, and you come to an emergency department and it's free. If you go to an urgent care, you got to pay. So it will push a majority of patients still to go to an ED because it's free, as opposed to going to an urgent care that's not. So something to consider with the current state of how we bill people, but it could be a consideration.
Good point. Frank?
Jason, that was a great point. I was just going to comment on Tammy's point that there, in that last bullet, there is a lot of detail that would still need to be worked out. And just to be clear about that, obviously it doesn't need to be worked out now. but you would still need an accepting physician to review and accept that patient onto that inpatient unit. And then if there's disagreement about whether the patient meets appropriate level of care or not, there'll need to be a mechanism for adjudicating that, but there'll need to be an accepting physician. And in many cases, when it comes to the need to go to a medical ED, often it might be the accepting physician on that inpatient unit who might listen to the story and say, you know, I think I need labs, or I need some other clearance before they come. But I'm just highlighting that there's a lot more, there is more to work out beyond this. In theory, this is a good idea if we had the beds, but and we work out these details at a later date.
Carlos.
Yeah, I just wanted to, you know, the same bullet. I think it's going to be a difficult transfer from urgent care unit to the ED, whereas the flow would make more sense to go the other way. So that, you know, I mean, I think once we have a kid in behavioral health care, urgent care, to go to an emergency room, I think it's going to, and transportation may be a problem, and as you guys have said, you know, accepting the care in the ED from an urgent care unit will be more difficult than the other way around. So that, you know, maybe triage, as I've tried to say before, should come from the ED to behavioral health. But I don't know.
That's a tough one. I kind of struggle with that one, because I think what we're envisioning for the urgent care is that for children who have behavioral health needs, the idea is to be able to avoid the ED altogether whenever possible, and go to the specialized level of care that we're envisioning for urgent care. But if all these young people have to pass through the ED first in order to get urgent care, I think that defeats the purpose. What are your thoughts on that?
You know, I think it'll be the ideal situation for people to avoid the emergency room, but I think that you know, you're taking a risk, and you know, maybe part of what our emphasis should be to beef up emergency room triage so that we can make these transfers really quickly and not have people waiting, rather than just avoid them altogether and maybe miss some cases that really belong there and then have to backpedal and figure out a system to get them back in. But
Okay, let's just, so yeah, I think excellent points. We'll have to, clearly we need to be very, very clear in this section on target population so that it's very buttoned up, because that's a very important issue. And so we'll definitely spend some more time on that. Looking at the clock here, it's 10:27. So let's just see if we can cruise through the remaining slides. As far as services go, you can see here a few bullets that are coming right out of the narrative report. Again, this idea of assessing whether an individual's condition requires medical attention in a hospital or detox or withdrawal management. We talk about providing suicide and violence risk screening in the urgent care and planning as well, transportation to support that bidirectional flow that we've been discussing the last few minutes. Having formalized relationships with those next levels of care. That includes the CSUs, but also inpatient, as we've been talking about. Real-time bed tracking again, and then coordinated connections to ongoing care. Let's just move through and get some final thoughts. In terms of discharge and connections, as we've talked about, the idea here is that the urgent care is less than 23 or less than 24 hours, keeping in mind that crisis stabilizations as 1 to 14 days could be a next level of care out of the behavioral health urgent care if young people are not stabilized at the 23rd or 24th hour. If they are discharged, they should be discharged with an appointment for their next service. Direct admission rights to those levels of care, as we've talked about, the capacity to make the direct referrals. And the idea that urgent care is if transport to ED isn't required, the urgent care should not refer them back to families or mobile crisis or police to make that transport. They need to have the capacity to do that as well. there's a lot of information on capacity. So the challenge of 30 minutes is going to hit us now. A lot of information here on staffing. I'm going to pause just within the interest of time. I know there's a lot of details to work out on funding, and I just want to turn it over to Tim to wrap up in terms of what we're going to need to do on our side to finish up the narrative report, and then how we might want to make sure we engage this work group before anything is finalized. Tim?
Yeah, so I think we are assuming that one of our, what we're going to be asked for is potentially some kind of price tag, when I'm not sure that we, in fact, kind of were prepared for that. We certainly didn't do any fiscal analysis of these practices. And I think there are some documents that were shared federally for some of these, but I think we would probably just take some rough guesses around staffing and costs. And of course, that would just be for kind of the annualized costs, not for brick and mortar and all the other challenges that come with this level of care. So we're going to likely send something out for folks' review, but it's very likely to be a very broad range of potential funding. So it's really probably much more along the lines of getting kind of some ballpark figure. So, potentially even a $2 or $3 million span of recommendations. Obviously, these are costly. The other part of it is, we have heard of suggestions in a variety of the recommendations as they begin to be developed and put forward to potentially stand up parts of it, pilot, just test out different components, if you will. There's some challenges in that also. So we have to kind of see where this goes. But I think our next step is to finalize these. What we do need to pivot in terms of the time that this work group is spending in terms of getting to the crisis stabilization recommendations. So what we'd like to be able to do is to continue the finalize the recommendations, but get them back out to you all electronically, and then have folks continue to just give us suggested edits from this group moving forward. A lot of the conversation that we keep coming back to are challenges that we know if we were to implement this today, there are other domino things that need to occur. So those are not the edits we're looking for, because we understand. So we understand the staffing, all that, and we should acknowledge that and put it in context that a lot of other things need to happen. So for example, again, to be successful, there needs to be enough inpatient beds. So we welcome those comments. We're not suggesting you don't make those, but we would welcome those. But what we're really trying to focus on is the concrete model there. So if folks can give us that feedback, and again, we're going to take a stab at financing, and there's probably a whole bunch of folks on this meeting, and all those who have been participating who are a lot more familiar with costs associated with this. So we would rely on you all to kind of weigh in on that. And again, our desire is not to get an exact annual budget there, but at least some kind of broad parameters by which we can give leaders some idea about the investment that would need to occur in this. And again, I think that's aside from brick and mortar siting. So that's really what we're trying to do there. So that's comment on that. Any quick follow-up questions or comments? Giving you 30 minutes back if you joined late. We were spending only 30 minutes today. There's a number of folks on and a number of folks who could not make it, who are heading to the LOB for a hearing on the Children's Committee. So appreciate everybody's joining, and just turn it back to you, Jeff, to wrap up.
That's it. Consider it wrapped up. I appreciate everybody's time. We will we'll be back in touch with you with more, and look forward to kind of wrapping up the work of this group. I appreciate everybody's time and efforts on this. Take care.
Bye.